Well, a very warm welcome to this lunchtime lecture. I'm Susan Mickey. I'm Professor of Health Psychology and Director of the Centre for Behaviour Change here at UCL. And I'm delighted to introduce two of my senior colleagues to speak today. Dr. Fabiana Lorencatto and Dr. Danielle. They're both leading behavioural scientists at UCL with a background in psychology and particularly interested in studying health professional behaviour, understanding it so to be able to effectively change it and thereby improve the quality of healthcare. They're both going to speak for about 15 minutes and then there'll be hopefully 10 minutes for you to ask questions and make comments at the end. So do take a note of anything that comes to your mind during it. So to begin with, I'm delighted to introduce Dr. Fabiana Lorencatto.
Hi everyone, my name is Dr. Fabiana Lorencatto. I'm the research lead at the Centre for Behaviour Change and I'm delighted to be here today with my colleague Dr. Danielle to talk about how we can apply behavioural science to design more effective interventions to improve clinical practice. And thank you very much for giving up your lunch break to come and listen to us speak. Susan's introduced us, but I just want to quickly introduce where we work, and in case you're not aware of the Centre for Behaviour Change at UCL. It was set up about 5 years ago now, with the aim of, well, in recognition that psychology is not the only discipline with expertise and knowledge when it comes to changing behaviour. So one of our aims was to bring together and harness the breadth and depth of academic expertise in behavior change across disciplines within and also outside of UCL and help translate that knowledge and evidence into practice, so to practitioners and policymakers in different sectors. We offer a range of activities related to behavior change. We do training, we do teaching around behavior change, as well as consultancy and put on lots of events. But research is obviously a big focus for us, and we've got a diverse portfolio of research around different aspects of behavior change, from patient self-management to environmental sustainability, so not just health-related behavior change. But as Susan said, implementation science, which is a study of healthcare professional behaviors and how to improve them, is a real focus for us, and we have numerous multidisciplinary grants on at the moment around topics such as reducing inappropriate use of antimicrobials, ensuring blood transfusions are administered and prescribed appropriately, to hand hygiene, infection control, etc. So today, Danielle and I are going to talk a little bit about why should we think about behavior when it comes to quality improvement in healthcare. I'm going to talk a little bit about some of the typical limitations, perhaps, in current approaches to designing quality improvement interventions, and then move on to provide a very brief overview of a behavioral science approach to changing healthcare professional practice, which is the behavior change wheel approach, developed by Susan and colleagues in our group. And then Danielle is going to take the abstract and sort of apply it to some concrete examples of how you can use this approach to design quality improvement interventions in implementation. So why should we think about behavior? So evidence-based medicine or evidence-based practice has risen to be the gold standard when it comes to medicine. And there's often this hope or assumption that if we simply tell doctors and healthcare professionals what they need to do, what best practice is, that that's what patients will get. They'll get the right treatment, they'll get the right test, they'll get the right advice. There'll be a smooth translation from evidence into practice. But I'm sure, as probably a lot of you have experience of or might recognize, that's rarely the case. The real world is much messier than that. And often we find that doctors actually know what the guideline says, what the best practice should be, what the evidence is, but for many good reasons, it's not easy to do that in practice. And evidence doesn't always get translated in a linear way into practice. And we have lots of evidence of these evidence practice gaps for lots of different aspects of clinical practice. So despite the availability of training and guidelines, many healthcare professionals don't always act in line with these. So things like hand hygiene compliance and infection control, prescribing of different types of medications. So for instance, the overuse and misuse of antimicrobials and antimicrobial resistance, the growing public health threats, are a really good example of evidence practice gaps. Referrals to other services. I do work in blood transfusion. I still find the statistic shocking that 1 in 5 blood transfusions are actually medically unnecessary, despite how scarce and costly these resources are and that they can pose risk to patients. And indeed, overall, there's evidence that, for instance, in the Netherlands, that 30% to 40% of patients don't actually receive evidence-based healthcare, and sometimes patients even receive care that's unnecessary or harmful. Now, this leaves the question as to why. And I think it's important to recognize that guidelines alone, whilst important, are often insufficient and they won't implement themselves in practice. And many of these things we've been talking about, such as prescribing, making referrals, hand washing, these are all forms of human behavior. And if we start to recognize that clinical practice is a form of human behavior, we can start to think about how we can change that. And improving implementation or improving healthcare depends on behavior change, not just of healthcare professionals, but many different people within the system at different levels. So everything from healthcare professionals to support staff, commissioners, policymakers, and patients themselves. And these behaviors don't occur in a vacuum. They interact with one another. So the behaviors of different professionals will interact and they will influence one another. So for example, if we take what seems like a simple behavior, such as a nurse disinfecting their hands at the patient bedside, well, the nurse's behavior might be influenced by the behavior of a more senior doctor and whether they demonstrate and model the behavior and actually do the hand hygiene behavior themselves. Their behavior might be influenced by the patient and whether they actually demand or ask the nurse to clean their hands, but also the behavior of the domestic staff in the hospital who need to ensure they are refilling the alcohol gel dispensers. So multiple behaviors, multiple actors, all interacting to form a system of complexity that we need to recognize when it comes to thinking about quality improvement. It's not straightforward, it's actually quite complex, and it relies on behavior change. However, although there's been significant investment of time and resource into designing interventions to improve the effectiveness of healthcare, when we look at their evaluations and evidence syntheses, so systematic reviews to look at the effects of these interventions, almost always what we find is that they work-ish. They have modest effects on clinical practice, and sometimes they work really well, and other times they don't work very well at all, or sometimes can make things worse. And we don't really know what's driving this variability in outcomes. And there's lots of factors that could be contributing to this. But one key limitation is that often when people design interventions to improve clinical practice, they're not approaching it in terms of thinking about behavior, as I've just said, really important to implementation, but often ignored when it comes to designing interventions. Instead, interventions to change clinical practice are often designed on what's been called the Isligiat approach to designing interventions, which simply stands like it seemed like a good idea at the time. By that I mean, we all do behavior, right? We're all human beings. It's common sense. We all have our implicit models and ideas as to why behavior is as it is, why people don't do something, or why they do something. And sometimes that's right, but sometimes these implicit models are wrong and are biased. And instead, if we design interventions on this Isligiat approach, what I mean by that is we often don't have a rationale. We're designing interventions based on these gut instincts of what needs to change. More often than not, it reflects this assumption that if you just tell people or just educate, they will change. Don't get me wrong, education is absolutely key and important, as is knowledge, but we know that the influences on behavior are much more diverse than just knowledge gaps alone. Or this assumption that it worked elsewhere, so surely it can work for this behavior too. I've had colleagues of mine in transfusion say, well, we'd like to really learn from the public health successes of smoking. So can we take what's worked for smoking cessation and apply it to change blood transfusion practice? Smoking and prescribing blood transfusions, very different behaviors. What's driving whether or not someone quits is going to be very different when it comes to decision making around whether or not to give a blood transfusion to a patient. So we can't just pick one intervention from one setting to another. So why is this a problem? Don't get me wrong, there's definitely a place for gut instincts and intuitions and familiarity with clinical experience. You know, sometimes Isligiat does work, but more often than not, it doesn't. There's a real risk that we're going to invest scarce resources into an intervention strategy that's maybe not targeting what's actually driving the behavior. But more importantly, without a rationale for why we chose that specific intervention strategy, we can't learn from our implementation successes or failures. So what we end up with are these elusive black boxes that are often implementation interventions where we don't really know why we chose that strategy. We often don't describe what's in them very well. So it makes it very hard for one to replicate or scale up that intervention either within the same setting or to learn from it if it doesn't work. So how can we be better? How can we be more systematic? So this is often our starting point to introduce a behavioral science approach to designing interventions, not just in quality improvement, but in general. So let's take the analogy of going to see your GP with some kind of physical ailment or symptom that you feel needs treatment. You would hope, although we know this doesn't always happen, that the GP would first examine your symptoms, make a diagnosis as to what they think is wrong with you, and then prescribe a treatment, let's say a drug, match that to your symptoms so that they are giving you the drug or treatment that's most likely to treat your symptom specifically. Why don't we approach behavior change in that same way? This is the exact opposite of Isligiat. So the key principle that we're going to unpack today is this notion of we should do a behavioral diagnosis. So we should look at what are the symptoms influencing the behavior, the barriers and enablers, and then match the choice of intervention strategy to that understanding of the behavior. This is what's considered best practice, actually, in terms of evidence-based best practice when it comes to intervention design. The Medical Research Council recommends that we should do this when we design interventions. We should design interventions on the basis of a theoretical understanding of the behavior of interest. But what the guidance isn't as good at explaining is how do we actually do that? So it's lots of recommendations that you should think about what's driving the thing that you want to change. You draw on theory to do that and design a theory-based intervention, but how do you actually go about doing that? And this is where the behavioral and social sciences can help. There's actually a number of disciplines that are specifically dedicated to studying human behavior. Psychology is just one. You have anthropology, sociology, politics, history, geography. Loads of different disciplines have a lot of expertise in terms of explaining and understanding behavior. At this point, I usually pause to say that we're not going to tell you the magic bullets or magic answers when it comes to changing behavior because they do not exist. And that's not the point of what these disciplines aim to offer. There's no universal truths of what will always work to change behavior. But what these disciplines can offer are theories, frameworks, and methods for understanding behavior, so what's driving behavior and how to most effectively change it. So today we're going to briefly give you a high-level summary, emphasizing that because it's actually a lot more complex than what I'm going to talk through now. But we're going to introduce the behavior change wheel approach, which comes predominantly from psychology, but we're a multidisciplinary behavior change center here at the Center for Behavior Change. And it's just one approach that's aiming to basically put the flesh on the bones of that Medical Research Council guidance. So to unpack the how do we design theory-based interventions in a systematic, transparent, non-isligiat approach way. And what it offers is a number of interrelated theories, frameworks, and evidence and principles, and a basis for linking our behavioral diagnosis to choice of intervention strategies. And it aims to bring and synthesize together the different theories and evidence we have currently in terms of knowledge around behavior change and translate that into a stepwise approach that's transparent to designing interventions that's hopefully useful to non-specialists in theory, so to policymakers, practitioners, researchers, etc. These are the key steps in the behavior change wheel approach. There's 4 sort of key steps in it. The first is being precise about defining your problem in behavioral terms as precisely as possible. So mapping out that system of interacting behaviors and actors and thinking about who needs to do what, where, differently, and when as the first starting point. Then doing that all-important behavioral diagnosis to understand behavior in context, to identify what is it that we need to change, what's driving behavior. And then using that behavioral diagnosis to match your choice of intervention, to make a theory-based informed decision as to what's most likely to be the effective and relevant type of intervention, so avoiding designing interventions based on gut instincts. There's a number of different frameworks that can be used to facilitate progress in each of these stages, and they are all interlinked, so it is sequential. Today, we don't have time to go through all of them, but I'm going to briefly talk you through doing a behavioral diagnosis using one framework of behavior change and then using that behavioral diagnosis to pick the interventions. So starting with behavioral diagnosis. If we think about that, what I said earlier, that clinical practice is a form of human behavior, it can be understood and explained using theories of behavior change that have been used to explain and predict behaviors in the general population. So ideally, we should use theory to do a behavioral diagnosis. It helps us think about, gives us a framework for organizing the different types of factors that might be driving behavior. So as a psychologist, when I say the word theory, usually this is when people start rolling their eyes and wanting to run for the hills and switch off. I don't blame you. Theory is often seen as something that's a bit inaccessible, a bit mystifying, a bit confusing. And even in our discipline, it's confusing. There's lots of theories of behavior change out there across the disciplines, 82 of them to be precise, which are summarized in this book. And we don't really have guidance for picking one theory over another. So within our discipline, there's been efforts to try to reduce complexity by integrating and synthesizing theories into a minimum set of constructs that are the essential components that drive behavior and need to be there. So this is one attempt to synthesize across different theories, and it's a simple model of behavior change developed by Susan Mickey and colleagues, which says there are 3 basic preconditions that need to be in place in order for your desired behavior to occur. Quite simply, the person needs to be ready, willing, and able to perform the behavior. They need to have the capability, the opportunity, and the motivation to do that behavior above all others. So these can all be broken down further. So by capability, we basically mean you need to have the knowledge and the physical skills to perform the behavior if necessary. Motivation, you need to think that it's something worthwhile, that it's relevant to you, that there will be positive consequences rather than negative consequences. You have the habit of performing that behavior if that's relevant, that it evokes positive emotional responses, etc. So it's about the reflective, what you think, as well as how you feel. In terms of motivation and opportunity can also be broken down into physical opportunity. Do you actually physically have the resources, time to do the behavior, the opportunity and access to what you need, as well as a social environment. So social norms and culture around that. Is that something that's acceptable, that's standard in terms of your social circles? And all of these can either be barriers or enablers to performing the behavior. They can either get in the way or make it easier. These can be broken down even further. I'm just going to very briefly flash this up. This is an elaboration of COMBI. It's the theoretical domains framework, which says these basically are 14 domains. It's a synthesis of 33 different behavior change theories and into 14 constructs that represent different types of influences on behavior that map onto COMBI. But as you can see, knowledge is just one of them. It's everything from emotions to optimism, social influences, beliefs, whether it's something that we think fits in with our identity. And what we aim to do with the behavioral diagnosis based on these theories is basically to collect data on what role does capability, opportunity, and motivation play in shaping our behavior. We might do that by doing interviews with people, focus groups, observations, questionnaires, asking questions around each of these to understand if they're a barrier or an enabler. And I won't go through examples of questions because Danielle is going to talk through a behavioral diagnosis based on COMBI in the context of implementation shortly. But what we often find when we start asking questions around each of these is that these are actually very complex behaviors, and we find barriers and enablers within each of these that interact. So there's lots of influences on the behavior beyond knowledge. So we need to consider a broad range of intervention strategies beyond education so that we can do that all-important matching of the treatment, so the behavioral intervention, to the behavioral diagnosis. Again, this is facilitated by using a theory. We like a framework. We like frameworks in our discipline. They just make life easier and they're useful for structuring our thinking and communicating our process. So ideally, we need a framework that outlines the whole range of different types of interventions that are out there. So our starting point was to look, well, is there any of these frameworks out there? And we actually identified 19 frameworks in the literature, not just in health, but in different disciplines. But again, a bit like with lots of theories, there was lots of frameworks out there. Not a single one was comprehensive. Some of them were more focused on things like biases, and others were more social factors. So there was none that was comprehensive, and none that actually linked to a model of behavior change to enable us to say, well, this is a type of intervention that is suitable to address this type of influence. So we simply synthesize these frameworks. I say simply, a bit more complex than that. We synthesize these frameworks into an integrated framework of different types of intervention strategies that was linked to a model of behavior. And this is the result of the synthesis. This is the behavior change wheel. It has theory at its core. The COMBI model is in the middle, so capability, opportunity, motivation. And around the perimeter are 9 different intervention functions, which are simply a high-level summary of a means by which we can change behavior. So one intervention function is our beloved knowledge, increasing knowledge through education. Or so you can use education strategies to increase knowledge or understanding. Or there's, for example, environmental restructuring. The very popular nudge-type interventions often fall into that. So that's changing something about the physical or social environment to encourage behavior change. And these are 2 very popular or prominent types of interventions, but they're only 2 out of the 9 high-level categories. There's also other ways we can change behavior that we should think about when we're thinking about what type of intervention to use. So everything from persuasion, giving incentives, coercing someone, not very ethical to do, but sometimes done, for instance, through punishing drink driving legislation. That's an example of coercion. You might lose your license if you're caught driving under the influence. Training, modeling, etc. I'm not going to go through all of these, but what I want to say here is that there's lots of different types of interventions out there beyond education or changing the environment. And we should think about all of these when it comes to picking the type of intervention. So how do we match the 2? I promise it's my final slide, Susan. You might be thinking, as I said, some of those examples, that some of these might be more relevant to changing different types of influences on behavior than others. And indeed, that is the case. To increase psychological or physical capability, you might use the functions of education or training. To increase motivation, you might use persuasion, incentivization, coercion, or modeling. And to increase opportunity, you might change something in the physical or social environment or restrict the opportunity to engage in the behavior. So different functions from the wheel are more relevant and effective to addressing barriers and enablers within different components of COM-B. And we've mapped the two tools together based on expert consensus with experts in behavior change to propose pairings between types of interventions that are more relevant and effective to addressing different types of barriers. So this is meant to be a tool that guides you through that process. So you've done your behavioral diagnosis using COM-B. This enables you to move to diagnosis to think about which types of interventions you might choose to do in your context rather than going to ISLIGIA. So I've talked about this at a very high level. I'm going to hand over to my colleague Danielle now, who's going to talk and give you an example of how to use these tools specifically in the context of understanding and designing interventions to change professional practice.
Okay, so Fabi's done a great job of telling you about these tools, and what I want to do now is pull some examples from the published literature to give you a flavour of how these different tools can be used for different purposes in the field of quality improvement and implementation science. And that really is the key point here, is taking the tools and using them for specific purposes. So in the interest of time, I'm going to talk about 3 different purposes and give you some examples from the literature and point you in the direction to find out more about how to go through this process step by step. So firstly, I'm going to talk about exploring implementation problems. So when things aren't working in the way we want them to, how might we explore them using these tools? Secondly, I'm going to talk about how we design an implementation intervention. And finally, I'm going to talk about what we do if we already have interventions, which we often do in a healthcare context, but we want to make them better. So we want to work backwards. Okay, so often this comes down to what questions we're asking. And I think one of the key questions that are often being asked in this context is, why is implementation not working? Why are people not acting in the way we want them to? So as you will have seen from Fabi's outline, we can use COM-B or the theoretical domains framework, so that elaborated version of COM-B, to explore our implementation problem. So what is driving that problem? What are the barriers and facilitators that are preventing healthcare professionals from acting in the way that we want them to or they want to? So when we talk about this, we're sitting at this stage of the steps. So we're going back to this, thinking about what is the behaviour we want to change and what will it take to bring it about. So as Fabi mentioned, commonly used methods for this are qualitative interviews, focus groups, but it can also be done through survey designs more quantitatively. And we can use COM-B and the TDF to structure data collection tools and analysis approaches. So we can tease out which of these drivers and which of these influences are driving the specific behaviour. And there's some great papers out there that guide you through this process and give lots of great tips on how to do this effectively. So if you are interested in this, I would point you in the direction of these 2 papers. But the example I'm going to talk about now is around this study that wanted to improve medication management in multimorbidity. So this is managing medication for patients that have multiple medical conditions that are being treated in parallel. And you can see at the bottom here, they very specifically outlined the behaviour that they want to understand. And this is really important to do, because if you're not specific enough about the behaviour you're looking at, then it's going to be much harder to really understand what's driving it. So here they're talking about the active medication review rather than passive maintaining the status quo for these patients with multiple conditions, to be conducted by GPs in routine general practice. So they're very clear about the behaviour they're looking at and the problem surrounding it. So The paper itself goes into a lot of detail around the work that they did to do this. But at a high level, they did a systematic review and they did qualitative interviews with GPs to tease out what was influencing their ability to display this behaviour. And I've just pulled out a couple of the findings to give you a flavour of which types of barriers might sit under which of the COM-B components. So you can see that under capability, there was this issue that the GPs were a little uncertain about which medications were most effective in the presence of other conditions. So this is a psychological capability issue. It's a lack of knowledge. In terms of opportunity, there was this social issue that the GPs thought patients wouldn't expect them to change the medication. There was this view that it was the cultural norm that once you're put on medication for a long-term condition, you will remain on that medication. So the GPs felt uncomfortable about raising that issue in a way that was unexpected for the patients. And as you might expect, there was also a time issue here. There was a limited window of opportunity for GPs to raise this issue with patients. So in terms of motivation, there was actually a perception that, is this the most important use of that limited time? So the GPs were kind of conscious of whether or not they prioritise this over other competing priorities. And related to that, on the automatic side, they tended to just print off the prescription automatically without actively considering whether to devote some time to discussing the management of medication. So I'm just giving you a flavour here of how this can be used in the context of health professional behaviour change. It can also be used across multiple studies. So this doesn't always require you to start from scratch and conduct interviews. It may be that there's lots of work already done looking at barriers and enablers to certain behaviours. And it may be you can take that information and code it to the theoretical models that we're talking about. And these are two really nice examples of that. So moving on, we might not just want to understand a problem, we might actually want to change it. So if we're asking the question of how can we make implementation more likely to work, we can use that behaviour change wheel approach from start to finish. So as Fabi outlined, this involves following all of those steps and using evidence-based decision-making to work through the stages. And so we're talking about going through right the way through to this end matching where we look at which types of interventions are most appropriate for our behavioural diagnosis. So just to stay on that example, they did do that. So they went further than just exploring the problem. They also tried to come up with an intervention that was theoretically developed and theoretically congruent with the behavioural diagnosis. So again, I've just pulled out some simple examples here. If you want to see the complexity of it, then I would recommend looking at the paper. So in terms of that uncertainty about which medications were most effective, the behaviour change wheel recommended enablement as the most appropriate intervention function. And this led to part of the intervention, which meant that two GPs supported each other to review medication and were in control of the time and location in which this took place. So that's an aspect of the intervention that you can see maps back to the theoretically developed behavioural diagnosis, intervention function, and so on. In terms of opportunity, that insufficient time required environmental restructuring. So there was an agreement to have a policy in place of protected time to review medication for these patients. And there was a standardised checklist developed to cue that review. So there was something there in the environment to direct people's attention to it, and they had the protected time to follow that. And finally, in terms of that motivation of, well, we have more important things to do, it's not the number one priority, incentives was the function selected, and this enabled GPs to award themselves continuous professional development points for enacting this behaviour. So I'm just giving you a flavour here of how this can be used. This topic might not be of specific interest to you, but there's many examples in the literature that have done this. So if you're interested in this approach, I would point you in the direction of these examples. And there's some great papers out there that really break down each step and show you how data informed each part of the process. So finally, I'm going to talk about refining interventions, because as I'm sure you know, we're not the first people to come up with the idea of quality improvement interventions. This is being done in the NHS and beyond all of the time. So what if we're already trying our best to do a good job of a quality improvement intervention, but it's just not working in the way we expected? Here we might want to refine. We might have limited resources and we might not be able to start from scratch and follow the behaviour change wheel through. So in that case, we can work backwards. So we can say, look, we've got this intervention. We had a reason for putting it in place. It might not be perfect, but we want to understand what it is doing and if there's any small changes we could make to make it do more. So this involves firstly identifying what's going on in our intervention. So what functions are existing within that intervention? And working backwards, using the behaviour change wheel in COM-B, what aspects of COM-B would those functions be targeting? So are those functions primarily targeting someone's capability? Are they primarily targeting someone's motivation? And importantly, are they the right things to be targeting? Because sometimes that's where you'll find the mismatch, and that's where you can make amendments. So I just want to point you in the direction of these two papers, which are a really great example of doing this, looking at the Sepsis 6 clinical care bundle. And I'm just going to talk you through, really briefly, how they employed that process. So as I said, the first step is really important here. So you really do have to spend some time identifying what is going on in the intervention. So they started by fully specifying the intervention content. And they did this by looking at observations of the intervention being delivered, looking at all of the intervention materials and conducting a content analysis of those materials. And they pulled out all of the intervention functions that were there. And they found 7 functions in this case. You can also break this down further, looking at what we call behaviour change techniques. We haven't covered those today because we simply didn't have time, but what they are is finer detail specification of these functions. They're much more specific things that you can pull out of interventions, such as action planning or goal setting or feedback, for example. So once they'd gone through this process and they had a really clear idea of what the intervention that they had implemented was, what it was actually doing, they then used the theoretical domains framework. This could also be done with COM-B if you want a higher level overview. And they conducted interviews with a number of people. So firstly, the intervention designers, so those that put together the intervention. Secondly, those who were receiving the intervention, so the people that were expected to comply with the change, the quality improvement intervention. And they identified the theoretical mechanisms of action that were going on. So how was the intervention working? What was it targeting? And what were the barriers and enablers around this? And this gives a really good opportunity because it allows you to look at what the intervention is doing and what the people actually needed. And that's when you can look at the mismatch between those two things. That's where you can see that's where we went wrong and that's why it's not working in the way we'd hoped. So again, I've just pulled out a couple of examples here. Some of the things that they changed were looking at the staff education program and addressing fears about harming patients. So this is something that the original intervention designers were not aware of, and it was not something that the initial intervention included. And it's a relatively simple change that might mean that a number of people then go on to comply with the intervention. The second thing they changed was they provided sepsis equipment bags to the night coordinators. So we can see this environmental restructuring added to the intervention that would not have been part of it if we hadn't taken that backward steps to look what was missing. And we can also think of this in terms of process evaluation. So when we evaluate our interventions, we often just want to know, did it work? And we often don't look at the potentially more interesting question of why did it work or why didn't it work? And these are some methods that can be used to answer some of those questions and really help us to make potentially small refinements to existing interventions that make much better use of these limited quality improvement resources. So just to summarize now, what we've hopefully put across to you today is that if we want to implement effective quality improvement interventions, we absolutely have to consider behaviour at all of these levels. We can't continue ignoring it, otherwise we will continue to waste our resources. Unfortunately, there's no magic bullet for doing this, and we're not pretending to you that we have all the answers. We wish that we did, and we're trying to build more and more answers, but this is where we are at the moment. And therefore, what we want to kind of put across as the key principles from these approaches is that we really need to avoid these kind of common sense hunches when it comes to interventions. We need to spend time understanding our behaviours before we try to change them. And specifically, we need to understand them in context, because the way a behaviour materialises in one hospital might be very different to how it materialises in another hospital or in a GP surgery. So we need to take the time to investigate and to diagnose the problem before we go on to prescribe them. And when we do go on to develop our interventions, we need to be as systematic as possible about it. We need to understand how we got from here to here and not just jump ahead with ideas of what seems like a good idea at the time. And importantly, whatever we do and whatever limitations are around us, we recognise that people are often doing these interventions in very high-pressured, resource-limited environments. But what we can all try to do is be really transparent in what we do, what we can do, and what we can't do. And this will automatically facilitate better evaluation, will provide opportunity for replication, and most importantly, learning from both our successes and our failures, because all of this will contribute to better interventions and ultimately better healthcare. So just to finish, in flagging up these steps and just emphasising that we've presented to you this tool set that we hope you can apply in different places for different purposes. And yeah, look forward to hearing your comments and any questions that you have. Thank you.
Excellent. Thank you both. Well, they kept to time, so we have 10 minutes for questions, comments and discussion. And what you've heard is a scientific approach to understanding and changing behaviour and some examples of clinical situations where this has been used. Anybody who'd like to ask a question, make a comment, put your hand up and a microphone will come to you. Yeah.
Hi, thank you. One of the things I'm most interested in is how you avoid bias. So with a lot of healthcare professional change programs, some of the things that we try to avoid in the first instance is that they are intrinsically built into their own behaviour set models that they've done for decades. So when you're doing the qualitative research, how do you avoid bias from just asking for their feedback on the way they conduct things to then implement a program that's designed to help them change their own behaviour? Is that something that you routinely see as an issue, and how do you overcome that?
I think that's a really good point, and definitely something that we have to be aware of. You know, as we all know, self-report is not always the best way to find out what's driving a specific behaviour. I think it's always something to be aware of, but I think there's a number of things you can do to try and minimize it. I think firstly, you can make sure you don't just talk to the people that are enacting the behavior. So obviously they're going to be an important group to talk to in your interviews, for example, but you also might want to talk to other stakeholders that have an involvement, but are not maybe the ones actually having to enact the behavior. And you might find that that sheds a slightly different perspective on what's going on. And obviously if you start to build up a similar picture or a similar narrative, it will increase your confidence that you are tapping into the right things. And I think secondly, you can triangulate using multiple methods. So you might conduct some interviews, but you might also conduct some observations or have a survey, for example, and see whether you're pulling out similar findings from the different methodologies. So I think those things go some way in addressing that issue, but I do think it's important to recognise.
And just to add to that, I think that's where using a theory, COMBI is one, but there's lots of other ones, a comprehensive model of behaviour helps, because we're often biased in our assumptions as to what's driving current behaviour, whether that's our experiences of it or someone observing it. And I think if you do ask around those, let's say those 14 domains in the theoretical domains framework, I always think, I'm going to ask a surgeon about how their emotions around transfusing. I've had some bad word responses, but actually more often than not, really interesting things, because I think the model kind of forces you to not make assumptions, but to look at the broad range of influences on behaviour. And if you ask and explore what role that is playing, you might find that actually it's not relevant, but sometimes it might uncover something that you maybe didn't think. And the nice thing about using these integrated frameworks is that some theories are very biased in their focus in terms of being about risk perception or motivation or social, and they're very great to unpack something in detail, but if you just draw on that theory, you might be having a very biased lens at the problem, whereas using these integrated theories makes you look at it from across the range of individual, social, cultural, and environmental drivers of the behavior, so we're at least exploring the role that each of these. So I think it actually helps it make me feel less biased when I'm going to do this. So sometimes I think it's not going to have a role. I have my own model, but actually when you unpack, it sometimes does. So I find it's helpful for challenging our perceptions and our biases on what we think is driving behaviour.
There's one there and then one.
Hello. Okay, I'm from Northumbria, but I'm originally from Thailand, and one of the things that I've noticed in healthcare setting is that there's a tendency to victimize whistleblowers, you want something to change, but then the system is already good enough. So how do you go about avoiding that?
Do you mean avoiding punishing whistleblowers?
Yeah, avoiding punishing. Mm-hmm. Or do you think in another way, that if whistleblowers are actually bad and they shouldn't be encouraged? I mean, what's your view on it?
So I think that's kind of going a little bit beyond kind of behaviour change interventions as such, but it's important in the broader context of, the quality improvement agenda and how we explore patient safety and quality improvement. I think there's been various attempts at measuring risk in terms of incident reporting and things like this and allowing people to speak up. I think it taps much more into the broader organisational culture and these broader mechanisms for how we effectively capture data on how safe things are and what the best ways to do that are. In terms of looking at whistleblowing as a behaviour, which you could do, would be an interesting thing to do. I suppose it would probably tap into looking at the broader culture around that and why there is that negative response. And you could even do kind of a COMBI analysis, almost at looking at how people respond to that and why people act in that way. I think it's a broader issue that maybe goes beyond the scope of this, but it's certainly something that we could apply this to.
Yeah, I'd see that as a barrier in the social environment. So it's almost something you need to understand the context in which you're trying to implement the intervention. We do a lot of audit and feedback research as a real culture, negative culture towards change and using feedback as a strategy, and audit fatigue and things like that. So I think you need to understand that context and recognise it. And, it's maybe reframing it, using local champions, almost reframing the role of the whistleblower. And actually, so there's strategy you can do about it, but that's a really nice example of the social barrier in the social environment.
Hi. In the context of taking this behavioural science approach and then you design your intervention, you talked about sometimes you'll get perhaps behaviours that you weren't anticipating, things like that, and go back through it. To what extent would you advocate the use of pre-mortems in a healthcare setting? So especially where you've got concerns about morbidity and mortality, so doing more extensive thinking through what those might be, what the implication might be. Or is there an element of actually you really need to put it into the real world to work out what's going to happen, and the sooner you can do that, the better, putting in place the controls that you can?
Do you mean in terms of kind of evaluating interventions?
Yeah, so sort of using pre-mortem techniques to try and work out.
What do you mean by
Sorry,
not familiar with, but
sort of policy-making techniques where you try and think about, if we do this intervention, looking ahead to 2 years' time and think what might have gone wrong, and trying to think about those various unintended consequences at the start, or actually do you just need to put things into the real world and see what happens?
No, I think you absolutely should think about those things at the start rather than rushing to implementation. I think there's scope to do that. I'm not familiar with that kind of methodology, but we're trying to work more with systems modeling and systems mapping as well, embedding that into this sort of mapping out the system of behaviors and modeling the consequences and seeing interventions as events in a system and the consequence they might have can be positive or negative. So I'd say absolutely there is a role for doing that at an earlier stage, and whether that's mapping it out in terms of the behaviors, their consequences, the influences, and understanding that rather than rushing to intervention. Absolutely, you might do that through structured discussions around this rather than primary data collection. So, we talked a lot about primary data collection, but it's not always feasible to do that. So sometimes you might have those sort of structured discussions around that. And we do work a lot with policymakers using this approach as well to analyze, more often than not, working backwards. So analyzing existing interventions, doing it with a strategic analysis, working backwards as well.
I think just to kind of echo that, I think it's about including stakeholders all the way through and make sure that we're not kind of just coming in and going through this linear process without understanding the complexity of the context. And by having the right people involved throughout and asking the right questions, maybe we can identify some of those potential unintended consequences, and they form part of this intervention development.
Okay, we've got time for one more question. I'm here.
Thanks. Really interesting. And while I accept absolutely that everything is context dependent, and the best thing in each case is to do a big study, I just wonder whether that also makes it very hard for people to say, well, we might have a problem, but we're going to have to do our own big study in order to even start. And I just wonder whether you're also finding things, or you're also able to help people by identifying similar types of problems and the places where behaviour change is most likely to be an issue. And so at least people who start to think about this have somewhere maybe to focus, if that makes sense.
Yeah, so I definitely agree, you don't always need to go through all of these steps from scratch. But I think just to emphasize as well, it doesn't always have to be a huge piece of work. These tools can be applied at very different levels, and they can be applied even with a group of people in kind of a risk committee meeting context, etc. So it doesn't all, we're talking about research projects and published literature, which is amazing, but it's not always going to be that. And I think it's always worth having some level of the process, even if it's on a much smaller level and a less resource intensive level, because although I agree with you that we want to kind of share and transfer learning, what we've learned a lot through our experience is that the context really is key, and that it might be that one little missing detail that hasn't come up in a discussion that will determine whether or not the intervention would be effective.
I agree. I agree. It is this balance. I agree. You can't generalize from something that's happened for completely different behavior. But prescribing, there's lots of what will influence prescribing of an antimicrobial versus an antidepressant is very different. But there's huge. It's a very rapidly growing body of research, I'd say, implementation science. So there are lessons to be learned around interventions that have been effective in changing prescribing practices that might give a starting point. So there is a lot to be learned out there in terms of generalizable lessons that might translate to. I think it's important not to hinge onto that just because it's definitely worked, but there are of course lessons to be learned from what's been done for similar behaviors, as you said, absolutely. And it's sort of it's taking it but being mindful of the limitations of how much you can learn. But of course there's literature out there to draw on and experience, and absolutely.
Well, sorry we don't have more time for more of your questions and comments, but just to say that this will be put on the web. So you had a huge amount of information this morning, so do go back and look at it again. And also, I didn't properly introduce the speakers in terms of their roles at UCL. So Fabi Lorencatto is the research lead at the Centre for Behaviour Change, so some of you may come across her in the future in that capacity. And Danielle is the Senior Teaching Fellow on the new, well, not new, launched in 2017, MSc in Behaviour Change, which is a multidisciplinary MSc and hugely popular. Can I thank you again for coming, and can we thank our speakers for a very interesting presentation and you for your very good questions. So thank you very much.